our final talk today, we have Dr. Amy Zhang, who is an assistant clinical professor on the glaucoma service at the U of M Kellogg Eye Center. Among her clinical interests are work in minimally invasive glaucoma surgery and home. Thank you. I was missing a word and my glasses are fogging up. Dr. Zhang is faculty associate with the wellness office as well. She's been looking into things like vacation utilization, in-basket burden, and she has an interest in improving ophthalmic ergonomics and looking into addressing drivers of burnout across our health system. And so she's going to talk a little bit about ophthalmology, and I think a lot of what she's going to talk about today is applicable to other areas of outpatient care. And then we're going to ask her lots of questions, and this is your last chance for flying monkeys, so let them fly. Thank you so much, Dr. Zhang, for being here.
Thank you. Dr. Cohen, for giving me this opportunity to come and talk to you guys. We'll first start off with an overview of what ophthalmologists or what ophthalmology is, and then sort of delve a little bit into some of the clinical burdens or some of the clinical challenges that we face in clinic. So I have no financial disclosures related to this talk. So what do ophthalmologists do? Many people think we just give glasses. That is not what we entirely do. So ophthalmologists are physicians that attended medical school, did a residency, and possibly further training to be able to do ophthalmic surgery. So a lot of how we're different from optometrists is that we actually do surgery. So we do procedures like laser procedures. We also perform eye surgeries such as cataract surgery, glaucoma surgery, other surgeries of the eye that you might have heard of. Despite what everyone thinks, the eye is actually very complex. So we actually have subspecialists within ophthalmology. So it's not just an ophthalmologist and that's it. If you look at the various layers that compose of the eye, there are different sections of the eye. Just to review a little bit of anatomy, there is a cornea, which is the clear surface of the eye. So there are cornea specialists. Yes, there are specialized ophthalmologists that only focus on just the clear part of the cornea. There are also the ones likely to do your refractive or LASIK surgeries that you might have heard of. The lens, which is what aging cataract is also something we as general ophthalmologists, as well as glaucoma, as well as cornea, also focus on cataract surgery. So that's sort of shared. And then in this big portion of the back of the eye, the retina is actually the layer that's transparent that fills like the back of the eye. So it's actually just a very thin layer. This void space right here is more of a aqueous or fluid filled. So it's not, but retina specialists focus on the back of the eye. So amongst ophthalmologists, we also divide further into different subspecialties. Our primary gadget that we use in clinic is this device called a slit lamp. And there are some ergonomic challenges with this, which leads to some of the musculoskeletal complaints that are prominent in ophthalmologists compared to your typical primary care physicians. And then in terms of surgical procedures, this is an example of a ophthalmic microscope that we use to be able to visualize the eye, and then we do microsurgery. So as you can imagine, the eye is very small. And so many of our instruments are very intricate, very small, and need some magnification in order to be seen on TV. So what drew me to the field? I think a lot of it was that I was interested in both surgery as well as clinic. And so surgical subspecialties tend to combine both of those. And I really enjoyed that. I enjoyed the longevity that you have with following your patients. A lot of other surgical subspecialties, you may just operate on the patient and then you never see them again. With ophthalmology, once they're your patient, they're sort of always your patient. Even after you operate on them, you still follow them for annual exams and such. So that really drew me to the field. And then most of the ophthalmologists, and if you take a general survey, ophthalmologists are pretty happy people, maybe because we have a fairly good life-work balance. Maybe we're just happy people, I don't know. But generally burnout is fairly low within our field. Although recently we conducted a survey after the COVID pandemic of ophthalmologists in the tertiary care setting. We actually found a tremendous increase, but still I think our increase overall is much less significant than other specialties. And then how cool is it to be able to restore someone's vision, right? So imagine for someone who needs, either refractive surgery, having that ability to wake up and not need your glasses, or having a visually significant cataract, which is illustrated in this picture right here. This is the lens of the eye. It's not the cornea, that's, but the lens. Clearly looking out through something like that would be very difficult. So doing cataract surgery using micro instruments would help to lead to a more clear lens and allow the ability to see. And so it was super rewarding that the first day after surgery that your patient can go from like hand motion to 20/40, 20/20 vision. That's quite remarkable. There's very little things in medicine where you can see that dramatic turnaround in a very short span of time. And then the other thing was you can actually see a lot of systemic pathology by looking into the eye. So without further instrumentation, meaning without like getting an MRI or a CT scan, just with your slit lamp as well as some lenses, condensing lenses to pass through light, you're able to visualize arteries, blood vessels, optic nerve, everything by looking through someone's eye. So you can identify a lot of pathology even without adding other things. A lot of my colleagues are also super interested in gadgets and equipment. We are coming out with newer ways of imaging the retina or imaging the optic nerve. So there are special cameras or OCTs, which are using kind of light coherence tomography, assessing how the nerve looks, how the retina looks, looking at the various layers up to the micron level. So it's quite interesting. And then I think with AI, there's a lot of modalities that could be shifted to looking at that. So I think ophthalmology is just a good blend of almost anything that someone might be interested in. So that's sort of what drew me to the field. Now, switching gears a little bit, as I mentioned before, even for ophthalmologists, we're starting to find out that, there is an increase in terms of burnout and fatigue. And why is that? I think just overall in medicine, there are contributors to burnout that are multifactorial. And a lot of this overlaps with the clinical inefficiency. I think you can talk to any clinician in any setting and ask them, what really leads to your burnout or fatigue throughout the day. And they'll tell you that my clinic or my surgery or my OR is not run efficiently, okay? And then another thing is that as ophthalmologists or as physicians, we are really trained to practice at the top of our license. And what that means is we should be doing the things that only physicians can do. So only eye surgeons can operate on the eye, right? But someone else can help us like prepare messages, get the triage notes ready, prime up the RX refill so that it's ready to go. Having us do that initial dig is probably not allowing us to practice at the top of our license. We have only so much finite time. And if we're spending a lot of our time doing that work, then when would we have time left over to actually do the surgeries, to see the patients, to actually define the diagnoses? And then finally, if we have a little bit of time, because of my personal interest in ophthalmic ergonomics, there is, this idea of burnout contributed by chronic pain, which may be prevalent if you have musculoskeletal diseases. So, oh, go ahead.
Sorry, Dr. Zhang. Silly question. What is the difference between ophthalmology and optometry?
Yeah, so optometrist goes to school just for glasses and some eye conditions. They don't have to finish medical school. And ophthalmologists go through 4 years of medical school. You have to be a medical doctor first, and then you match into a residency in ophthalmology. And after the 4 years of residencies training specific to eye health and all the surgical consultations, as well as the various clinics, And then we may do another year or two of further specialization, depending on whether you go into retina, oculoplastics, cornea, and glaucoma. Yeah. So when we think about clinics, just in clinics in general, I think the biggest factors that we should think about are space, staffing, systems, and scheduling. Okay, so in terms of space, I think when we design rooms or design clinics, we don't oftentimes think about what's the most efficient way to move patients through clinic. Instead, we're told, here's this new building, ophthalmology, come in, staff it, right? And there's not really a great layout for what the patient flow is. And I think there's definitely room, if we ever get a chance to build a new space, to think about it in terms of various flows through various clinics and how should rooms be organized. In terms of staffing, as we probably know, or even if you don't know, even if you just drive down the highway, there's always for hire signs everywhere, right? Much the same within medicine. I think a lot of the nursing shortage, ophthalmic technician shortage is definitely leading to lack of clinic efficiency. So if you don't have enough technicians to work up your base of patients, of course, the flow of patients and the time in which you can see patients is delayed. I think having some system-wide, like thinking of a process in which you can improve clinic flow, or thinking about, what are some efficient ways to do that would also be important. And also, people don't think about scheduling. So people think, okay, everyone has access to the schedule. It's great. We can just make it work. Well, no, it's actually not the case. So when you create templates, right? When you create clinic templates, you're looking at, what is the most comfortable way to see X number of patients in that time? But what you're not taking into consideration is who is sharing that clinic space with you. Me sharing a clinic space with a retina specialist is very different than me sharing a clinic space with an optometrist. The utilization of different resources, the utilization of different equipment all matters. But that's not really reflected when you're looking at templates. And I think right now our current templates are set up as, how would you like your template design? Do you want to see how many patients do you want to see in what time frame, right? So if I give my suggestions of how many patients I want to see in what time frame, but my colleague who's also wanting the same thing, if there's a lot of overlap, but we don't have enough technicians to cover the number of patients that are actually arriving at those times, this is already a setup for failure. And then you throw in that anyone can overbook your schedule, anyone can put in patients wherever they want to, then I really think, why even bother having a schedule? We should just have a anything schedule, because if everyone can overbook, everyone can rearrange it, then the systems that you put in to facilitate that better flow is also kind of changed. So it's like having a dynamic look at, what's changing every day. And so my belief is that if there is a way to build a template that would be more efficient for new providers that come in, you have to think about how is the presence of adding a few more patients or their clinic schedule going to affect the overall flow. And I think all of that is really important to look at. And I don't think we're spending enough time looking at that portion, and we're spending a lot of time in the back end trying to fix all these challenges that are arising. So once again, with the clinical inefficiency, there are improved ways of managing patient flow through clinic. I think a lot of times we do time studies or we try to track how the patient flows. I'm just wondering, is there a way from the EMR standpoint, because everything is time-stamped and who is accessing it, to sort of back-end track that and look through how are the ways going through? Once again, I mentioned a limited number of technicians. Let's say there are 2 providers in clinic. We both have patients arriving at 7:45. Well, guess what? At 7:45, there are only 2 technicians. So if we have 4 patients arriving, right off the bat, 2 of those patients are not getting worked up because the other 2 technicians are not coming until later. And then just once again, like whenever you're adding faculty templates, you really have to think about what is existing and how does that add to further things. And then there's also the concept of limitation of rooms. So when we think about workup rooms, right? We have to have enough rooms so that the technicians can continually to work up patients. So if I just say, all the rooms are mine, and I'm running behind them occupying rooms, and my technicians, even if there are 6 of them, they have no rooms to work out of. So perhaps we should think that there should be some dedicated technician rooms and then certain assigned clinician rooms so that, regardless of how long it's taking me to see those patients, I'm not stopping the flow of workup. So thinking about those things are also important. And then once again, in a clinic, there may be only one OCT machine, which is that optic tomography that I was talking about, which measures like the thickness of the optic nerve or the thickness of the retina. Well, if you only have one of these and every single patient that comes through clinic needs that, then that's clearly going to be a bottleneck of where things are. So thinking about what your needs are, what the patient needs are, and trying to think how many of these you'll need, which may not correlate over to, well, according to metrics, we brought in X number of revenue, and you don't justify getting another OCT, but does the wait time for your patients also justify that? If we're making them wait 6 to 8 hours before they get their imaging. So switching gears a little bit, clearly I'm really passionate to talk about clinical inefficiencies, but that's not the focus of my presentation today. But if any of you guys have ideas about that, feel free to shout them out or share them with me. I'm going to focus more on the idea of practicing at the top of your license. So with the advent of EMR, certainly a lot of things did get better. So EMR is the electronic healthcare record. And so with that, a lot of things became better. I'm not saying it's a bad thing. Illegible handwriting by your physicians can now be read by everyone. Healthcare in terms of diagnoses and things could be shared across healthcare systems. This is all great. However, it has also led to this expectation that's sort of unrealistic in terms of how quickly physicians are able to respond to patient questions or demands. So with the pandemic, we actually saw an exponential increase in the number of these messages, just because no one was able to actually come in and see their physician. I totally get that more questions would arise. The problem with that is that when you're a physician, you're not just waiting at some in-basket, like waiting for messages to come in, seeing, oh, how can I answer that quickly, right? I'm also seeing patients, I'm doing surgery, and I really don't think the patient that's in front of me or the patient I'm operating on would really appreciate it if I was just filling out a few more messages, answering texts in between, right? For those tasks, they actually involve a lot of cognitive burden and a lot of cognitive attention, right? We want to be able to have our attention focused on some things that are really important. And having those delays or interruptions when you're trying to do a very complicated cognitive task actually leads to worse care for both the patient as well as the messages that you're trying to answer. So I think that's an important point that we need to remember. So I think some of the ways that we need to tamponade the expectations are that, number one, the in-basket should not be used for urgent issues. So if you need a response within like the next few hours, you need to find another way, not the in-basket. The typical time of turnover may be anywhere from 72 business hours. So I think, having the expectation is probably right, because we also don't want to have someone lose their vision and be like, well, I contacted you 4 days ago through the in-basket and you never responded, right? So it's not sort of an emergency way of contacting us. And then the actual problems with the in-basket burden is a huge problem. So at the American Conference on Physician Health, a third of the conference was actually focused on talking about EMR and the in-basket burden parts of it. I mean, that's a big portion of the conference to be talking about ways to alleviate EMR as well as in-basket burden. So I think, oh, go ahead.
Oh, sorry. I just had a question about like this increase in messages that you're seeing. I think this is an impossible one to answer. So if you have
Sure.
an idea, but these are new messages that are coming in that weren't being sent before. How much of them are new problems or new content that you weren't being asked before? And how much of it is visits that were happening, but now are messages. Does that make sense?
Yes, I think that oftentimes during the pandemic, people were trying to ask questions that should have been a clinic visit. So because they weren't getting that in-person or maybe even not a virtual visit, they were having to ask about their health concerns through the portal. But that's not what the portal should be used for. It should technically never be used for a new symptom or a new cause, because we really have to either at least set up a virtual visit or something more than just this messaging. So, but it's very hard to determine because I don't think people have looked at in baskets and really categorized like what percentage, even within our own in baskets, it's really hard to say like, well, what percentage is like patient asking about symptoms versus what percentage is refills or like, I'm not happy about my scheduling. How come like I want to have a next appointment, right? So knowing what those buckets are would be really helpful, but it's not very transparent or easy for me to see. There's not like a already divided folder for me. I just go in there, all the messages are there. So, yep. Any other questions? Oh, go ahead.
So I know that when I send a message through the portal to my primary care, I don't know if they're nurses, I don't know if they're technicians, but like somebody below triages them and often and answers a big chunk of them, and only some of them are actually left to the physicians to answer. And I'm wondering whether it's the same for you.
Yes and no, that's sort of what we're gonna cover in the ophthalmology call line. So it determines, like, I think within ophthalmology, we actually have a fairly robust in-basket handling system. So it's very rare that no one has touched the message prior to me seeing it. There are some better steps of maturing the message, meaning like gathering the information before I have to make that decision of what the answer is. Because if you just call with one symptom and I have no other context, it's not really helpful for me to answer that question, right? So my nurses or my technicians or my residents or my fellows need to gather more data in order for me to answer the question sufficiently. But that's, I think, a next project, like maturing the actual message of any clinical asks would be very important. And I don't think we do enough of that. I think a lot of times it's like patient asks a question, then it's just forwarded with the words, please advise. I don't even have the basic information, so I can't really advise that well. So I think being able to mature the message to its full potential will allow for better answering of those messages. So, I'm going to now delve a little bit into our technician call line, which is a subset of services that we provide. So when we think about how do patients get scheduled into clinic, we think in terms of the context of who schedules patients. So there is the call center agents, there are the PSAs, there is the tech triage in the various clinics. And so let's go through what happens to a new patient. So a new patient with somewhat routine-ish complaint, meaning they're saying, oh, I just want to get my annual exam, you know, can I get that scheduled? So what happens? So either comes in through a phone call or a referral, like a referral through our queues and various other ways. And a decision tree is applied for new patients. And these are decision trees that were built a couple of years ago that we came up with to better funnel kind of direct patients into the appropriate clinics. And they result in provider subgroups, visit type, time scale for the appointment. If for some reason the time scale doesn't match what's in the referral, or if the patient just says, oh, that's way too long, I can't wait 2 years before you can get me in. Our exams are mostly not 2 years, maybe a year. But, you know, if they're very unhappy with how long they're waiting, then they do have that ability to then be funneled into the tech or clinic in basket. This clinic or tech in basket is different from the tech call line. I just wanted to specify that. So what about a return patient? So established Kellogg patient calls in with symptoms. And this once again happens either through a phone call or referral. We don't use decision trees for return visits. Okay, so instead, we are dependent on the patient information and the last clinic note if they were seen by our clinics before. And then the call center has a protocol of what's considered urgent. And, but they're not asked really to make that decision of actually scheduling the patient. So they'll either funnel it through the two different pathways, which is the tech clinic and basket. So each clinic, like each Northville clinic or Ypsilanti clinic or glaucoma clinic, retina clinic has their own kind of or bundled in basket. And then there is the tech or clinic call line, which is what I'm going to talk about. So what happens with the tech answer line or the tech call line is that they triage patients with symptoms. And this is something that's slowly ramping up. So currently there may be 3 technicians. The goal is to maybe have 6. But even since the start of them, I think they've handled and are able to schedule patients and get patients in a more timely fashion than this other ways that we're going to talk about. So these other ways of triaging patients with symptoms are that there is a tech triage in each clinic. And it's a combination of phone calls and in baskets. What happens though with the tech triage in clinic is if your technicians are already super busy working up 50, 100 patients that are in clinic, they're probably not going to get to these triage baskets until later. There is an initiative towards before there are certain calls that are flagged as red calls, which are urgent, and they're supposed to take care of those within 3 hours or something like that. So they will keep an eye out for that. But I think the goal for the tech answer line is to remove these red calls to all of the tech answer line instead of the tech clinic line, because those technicians are still working in clinics, seeing patients, whereas the tech answer line, their sole job is to answer the urgent and address urgent patients. There is also fellows and residents that really help out within our subspecialty services. So the in-baskets of glaucoma, retina, cornea is mostly handled by technicians first and then routed to either the resident or fellow to further kind of mature the message or actually address the issue. And then out of those that the residents or fellows cannot address, because fellows and residents are MDs, then they get forwarded to the attending. So there is a big buffer in terms of our subspecialty clinics, but there are only so many residents and fellows. And I think most of them do not like having to do a lot of in-basket work rather than the top of their scope. But there's still a ton of patients, a ton of phone calls, and a ton of in-baskets. There's always endless in-baskets to do. And many patients actually fall between specialties or between sites, right? So a person who may be a glaucoma patient might also have a retina concern for which they see a retina doctor for. And they may see their glaucoma specialist out at Northville, but then they see their retina specialist out at Kellogg, right? So how do you categorize when it's cross multiple clinics and multiple locations, right? So I think, once again, having that answer of the tech answer line, which would address the main concern of the patient, regardless of where they were seen, regardless of what clinic, is super helpful. So once again, to advocate for this technician answer line, I think it would definitely allow for call center urgent problems to be addressed directly to the technician in a more timely fashion. They're able to triage and schedule the patients in a timely fashion. What I mean is oftentimes when you have the tech in clinic kind of triage these patients, they're saying, oh, Dr. Zhang, we have a patient. This patient I do think needs to come in urgently. When would you like to see the patient? Like at 2 o'clock, 3 o'clock, you have some openings. And then after I answer and I say, okay, let's take the 2 o'clock, they say, oh, I can't schedule. Let me tell the PSA to schedule them. So then they send a message to the PSA who says, oh, sorry, somebody already called and took that 2 o'clock site. And then they message me back and say, Dr. Zhang, I'm so sorry, but the 2 o'clock site got taken. Is it okay for the 3 o'clock? And I say, yes, And then they go, oh, I can't schedule that. So let me talk to the PSA. So how many of those back and forth messages am I now getting from that one patient request? What happens with the tech answer line is that they're able to determine how quickly the patient needs to be seen, and then they have the ability to actually schedule. So then they just schedule the patient, and maybe I'll get one message that says, FYI, this patient I think needs to be seen urgently. I scheduled it for like today or tomorrow. If there's any changes, let me know. And that's it. Yeah, go ahead.
The first thing I think of when I hear that is, would there be a physician pushback on the idea of like, hey, I'm in charge here. I can't let, you know, the people who are on my team below me schedule my day.
Sure, there are definitely physicians that believe that way, but do you really think that's the best way to practice for efficiency and handling?
Absolutely not. I'm just thinking it might be an
Yeah.
implementation problem.
It is an implementation process, but I think when we're looking at cohorts and what's better for the group, we can't have that more independent mindset. Sure, if you're the only person and yes, everything is your way, but then you would also have very specialized templates, right? Like no one can break these template rules. No one can ever overbook. I think that it would lead to a lot of problems. But yes, of course, there has been pushbacks like, well, I do like to know so that but then there might be the same physicians who, when you interrupt them in clinic, are like, why are you bothering me? Why am I being bothered to ask this question? Like, you know what my templates are. I don't see patients outside of these hours, you know? But I mean, you can't please everyone. I do think we need to have a system that at least addresses the majority to help out with that, because otherwise we'll never move any solution. There's never going to be 100% agreement to move forward a new plan. Go ahead.
You might cover this in a second too, so if you do, but as a patient, how do I get to the technician answer line? Like,
Yeah. So you probably would call, because right now there's not a way in the in basket where you could just specify, I want the technician answer line. So I think that there are two ways. One is through a patient technician ask, like one of those in baskets, like I need something urgently, and maybe the tech in that subspecialty clinic send it to the tech answer line. But I don't think that's the majority of where their calls are coming from. I think the majority of their calls are coming from the call center, where they're saying, hey, I have a patient who's calling about an urgent problem. I don't know what to do. And I think that's when they get tagged on to talk to the patient, to assess for the symptoms, and then actually then schedule the patient.
so generally everyone goes through the traditional, like call the call center and then
Yes.
it gets sort of escalated.
Yes,
Thank you.
yes. Yes.
I think on the last slide that for fellows and residents, this isn't like practicing at the top of their credentials. Is there a specialty or like maybe a training program for which it would be the top of their practice to be doing this?
I don't think I found anybody who feels like this is at the top of the practice. I think that certainly nurses and technicians help us out a lot in terms of doing that, but they also have a lot of other asks and obligations. And I feel oftentimes they feel like it's just them being moved to their pile of stuff that they have to do. But I do think it's a collaborative effort. So I think ultimately the physician is responsible for answering, but like I said, if we could mature the message so that it's the best message for the question, it would be a lot easier to answer than some vague message with barely any data and just like, please advise. I can't advise without knowing like how long has the eye been red, how many days, is there any vision symptoms? If none of these questions are asked, like I can't advise on anything. So, but I think oftentimes, residents and fellows, they're also trying to get their surgical training, right? They're trying to see patients. They don't want to be spending all the hours of their clinic just answering in baskets or answering messages, right? So, but oftentimes we have to recruit their help because there's just so many in baskets to do. Yeah. Good.
For the messages, is it just, you just type a message, or is it kind of like, because you were saying you don't know how long it's been like a problem or things like that. Is there a way to kind of make it so it's, because I don't know what it is. I don't think it was on a medical portal, but sometimes where it's like you fill out a survey where you're like, this is my problem, and then it like prompts you. And then they're like, well, how long has this been going on? Is there a way to kind of make it be that?
We do have that for the initial intake. So there is like how long has been going on, like, you know, is there any vision changes? I think sometimes when it's embedded in an existing patient and they're asking about their problem, it wouldn't trigger that prompt. But that could be something that is utilized, like perhaps every single patient who has that, we just send them the question prompts or the vision symptoms questionnaire and screen it. So I think what we're asking CHEPS to do is perhaps looking at, you know, when we do involve the technician answer line, does that lead to less back and forth messaging and more efficient care of the patients? And I think we would be able to see that, because even in my clinics myself, I've seen that when it's handled by the technician answer line, I'm having to do a lot less of like looking for times and approving, and it just gets on my schedule. And I do think that leads to less cognitive interruptions to the physician throughout the day, which is super important, because I think when you have a lot of interruptions, it disrupts your cognitive abilities and decreases the amount of cognitive capacity. And I think many of us are just burned out because we're cognitively drained. In terms of handling all of the actual patient problems throughout the day, you're having to have all these curveballs thrown at you and being able to address it, and then reshift your attention back to the patient. So that shifting is really a waste of actual time and cognitive abilities. So I think it's not ideal. So I think by having a service where it sort of addresses some of this in a more timely fashion would allow for less interruptions to the physician throughout the day and more effectively take care of patients.
Is there, like, to her earlier question, so like sometimes when you're having a question and you're online, there's like a chat, a bot that's actually like prompting and interacting with you. And you may not actually be with the human, but like it's learned enough of the prompts and the questions to ask. So is there a way, like some combination of natural language processing and AI could be used both in the process of like, in the note, like when a patient is filling out, that would, you know, prompt them real time, like, oh, you're expressing this, because it can like mimic you in some ways, some aspects, or at least.
I definitely think that's where the future is. The problem with Epic specifically is that they have a lot of control of what AI and what type of AI will be enforced. And they're collaborating. I think they are partnered with Microsoft, which owns Nuance, which is the dictation software that's actually doing a lot of the AI prompts and such. However, it just determines like when are they going to roll it out, for what platforms are they going to use it in. I even said many times before, like, I don't understand, even for scheduling, why can't we have a bot like anywhere else, right? When they're like, how can I help you with today? And then they list like 3 problems, like RX refill. Okay, I can help you. Which of one of these RXs would you like to refill, right? Like, these are not something that a human necessarily needs to interact with. But I think our limitations are in terms of the constraints of our like EMR and what we can carry out. And I don't think we can have outside programs that tag on to our EMR to do that, because I'm sure there are many firewall concerns and other things. So I think we're just sort of waiting on Epic. I do think that, I think internal medicine might be piloting some AI interface with that. I'm not sure if it's specific to InBasket versus actual creation of the note, but whoever is involved in that, feel free to chime in. I just heard about that, but I have not seen it.
They are doing a pilot on basically improving notes. Basically, a lot of the content gets lost sort of in the middle of it. So can they write smarter notes? And in a sense, that is matured the message, because sometimes InBasket messages are actually just forwarded encounters. There's no message at all. They just send you the chart for that encounter. And so having a better written note is, I think, where they're starving for that. So who knows? No one was talking about ChatGPT however long ago, so it seems so far in the future, but you never know.
Yes, yes.
Now, could you talk a little bit about, so I think sometimes, because many of us are engineers, we jump to technology solutions and we overlook human challenges. And so one of the things that I'd love for you to talk a little bit about is what is a process issue and what is an enforcement issue? In other words, is it that when someone forwards you the note, they can't answer it because they don't have the correct information, number one, and therefore they're forwarding it to you appropriately versus I can forward it to get it off of my list. The including of information, is it, part of what I'm trying to figure out is how much of this problem would go away with different management training, leadership incentives, fill in the blank. Not to in any way suggest that those things are easy. I think sometimes the technology solutions are easier, but to what extent is it we need to be improving job definition and training enforcement and follow up on doing those things?
I think that's actually a major factor. So I think the difference between humans and machines is that when a machine gets programmed to do something, they'll do it exactly the same every single time, right? When you have different humans, they forward you different things. Some people may mature the message all the way. Others may never mature the message anyway, regardless of whatever the ask is. It's always please advise. It's just move off to the physician to answer. It is somewhat technician dependent. It may be maybe that technician or other technicians have less training and they don't know the appropriate questions to ask. So finding out that would be super important. And then having the basic level of expectation, right? So what are the incentives to get a message right? So currently there aren't any. So they forward, it's the same thing as if they try to answer as much as they can. It's not like the person who does more of the maturing of the message gets like a bonus or says, oh, great job for reducing that. They have probably more messages to answer because they're taking more time to do that. So definitely there is that component. And I think that's why we do tend to depend on the technology side, because you don't have to train a machine. You don't have to argue with the machine like you didn't do this as well as something else, right? Because they just do it this way. Everything is the same. Everything is answered in that same format. And even with training, it's more of like how much of that is actually retained. And with our current model where we have a lot of turnover, how much of that is actually attainable. So if you train someone to that skill level and then they leave and then you have a new person, how much more time and training? And is that something that's also leading to them moving on because they feel like you're asking too much of them in their short amount of training that they received? So it's much more complicated when working with humans than machines. But yes, go ahead. Oh, did someone else?
Oh, sorry. Sort of piggybacking off of that, one of the things I think about is if you're trying to schedule an appointment and there's no more appointments, you say, sorry, there's no more appointments, you have to come next week or next month or next year. But for some reason, the in-basket is kind of like the emergency department of communication, and that like you can't say no in a sense.
Yeah,
Like at what point, this is about an opinion, and I'm sure it varies because humans vary. At what point do different providers ever feel entitled to just be like, I'm gonna be so paid a dream scenario, it's 5 o'clock and I'm just not answering any more messages today because I didn't get to it.
Yeah.
Like, is there ever a world in which like we do that with appointments in a sense,
Yeah.
but we don't do that with messages?
Well, I mean, there is that, right? So there is that like 72 hours before we get back to you. And there's only a limit to how many hours the physician can stay afterwards to answer in baskets after I finish off my charts, right? At some point, I do have to go to sleep and maybe get some rest before my next day or before my OR. But more so than that, I think many of us try to accomplish as much as we can, but when it adds up over time, right? Because if you don't answer those messages, there are new messages coming in. It's not like the next day it just washes and you're like, oh, you have a blank slate. So I think we do try to handle as much as we can, but like you said, and it just never stops, because even when you're sleeping, someone might be having a question and they can just ask or text, or, it's a lot easier. Whereas, I always think back like to what happened before we had messaging, the world, like how did patients reach physicians? Like how did they called, right? And they left a message. And then whenever the physician got to it, they answered back, right? But now we have so many different modalities of access. And I just worry, like certainly it's always good to provide more information, but is there a way to quantify, like, is this so much access has led to better healthcare? Did it lead to actual treatment of the patient? Did any health outcomes improve? I don't know.
Just to offer like a patient perspective, I have cystic fibrosis, which is like a lifelong chronic condition that often involves like really close relationships with your home clinic. And I remember before the portal was as common, just needing to ask a lot of questions of my physician, like, oh, I'm sick again. I'll probably need to be admitted. I have to get in contact with them. And at that time, this specific clinic, the phone tree was pretty brutal. And it would be like at least 20 minutes, if not 30, if not 45 of sitting, listening to the song that will never leave my brain. And during that time, I'm like really struggling to breathe, but I can't sleep or rest because I have to sit on the phone so that I can get to the hospital, And since then, like being able to send a message and know that they know everything about my health. We have this routine down, and they can say, okay, I'm putting in a direct admit, like it's significantly bettered my life. And I think it's important to hear that while also hearing that like it's significantly complicating a lot of providers' lives. So like, how do you balance that?
Well, I think the scenario you illustrated was really important, right? Because you have a chronic, like very urgent problem. You not getting admitted would lead to death or, really bad outcomes, okay? And the fact that I'm sure your in-home clinic or the site that handles your messages have a really good system of triaging where they can answer it in a timely fashion and where they do address it, right? I think it's different when it's different problems. When it's something like my eye itches, it's really irritated. My vision's fine, but it's really irritated, like, does that really need to be answered in terms of someone who lost their vision? Should I make that person who lost their vision? Oh, I'm sorry. Hold on one second. I have to address this really uncomfortable eye that is seeing great. And you who have no vision and we're trying to figure out if you're having a stroke. I think there's something to be said about different diagnoses and sort of the effort and care that's required. And it sounds like whatever model that clinic is using is very well done. I mean, clearly you're getting timely. And of course, if you're getting short of breath while on the phone, waiting for admission, that sounds quite emergent. Like versus something like, oh, I have a slight cough. Should I take, Tylenol or should I take ibuprofen for it? Which one of the two? Yeah, go ahead.
So I have two questions. One of them, to follow up on an earlier question, are you sure that for no one, this is not working at their highest level? I think there are some people for whom doing this would be allowing their job to be at a higher level. And so then to follow up on that, is there some level of empowerment that's lacking, which is why someone would forward you an email directly versus building it out? Like, so that combination of empowerment to do so, but then also this could be that for someone, this is actually elevating their level and kind of thinking about using people to their highest human potential.
You're right. I do agree with that because the technician answer line, the technicians in that line are operating at the top of their license and they do enjoy that. And then more of like, how do we find people at that top of the level who enjoy doing that, right? I think I was trying to say like a lot of the difficulties we've had in terms of assigning in baskets has been that nobody wants to touch them. Like there hasn't been, but perhaps like you said, if we kind of modeled it to allowing the technicians then to step off the floor and their sole job is the answer line, then perhaps that could be more appealing and something that they would do and would be at the top of their scope. Yes.
So we haven't had any real flying monkeys, and I'm gonna give you a good flying monkey, which just the like, what is the craziest idea you can think of that's ridiculous, but might lead to thinking about another idea?
Sure.
So hypothetically, suppose somebody had an 83-year-old father-in-law who was a practicing ophthalmologist who really needed to retire, but had no idea of what to do next and was not physically capable of going into surgery every day,
Yeah.
but really loved his work.
Yeah.
Be in a position of, I can evaluate and assess and hand off. Obviously, I'm being facetious, although I don't know what the idea is. But I am wondering about the nurse who doesn't really want to retire, but is physically taxed now, or the person who enjoys the work but needs the flexibility of being from home. You know, I want to, part of this is my last like opportunity for trying to impart some wisdom for you all. And one of the things I want us to be thinking about is the creativity of, is it a technology solution? We are talking a lot about AI, and when you talk about AI, the issue of job displacement becomes something of importance. And I'd like us to flip a little bit of, are there pieces of this work that there is someone out there who, yes, I'm retired, but I could do a couple of half days a week that might be really interesting, or I'm the med student who wants to match in ophthalmology. So just be thinking about the human capital of, we're really good at like trying to replace people with machines to do certain work. But I think sometimes we can be thinking about ways to more creatively use people in this multiple benefits of, it's not just that, oh, we can get this work done, but here are ways that we can be using senior citizens, which would also help quality of life issues in terms of sense of purpose or mentorship or so on. So that's my crazy monkey is, I'm gonna send my father-in-law to you.
That's great. We actually talked about that. So we actually talked about retiring ophthalmologists or optometrists or other people, like, could this be done remotely, right? Could someone be like not even in Michigan? And I think those are really good ideas. The implementation is a little bit hard because there are some rules across states in terms of management and liability and things like that, and whether they're covered by the university versus not. And then also once again, it comes down to funding, like how much would a retired ophthalmologist cost versus how much could technicians cost, right? So from a health system standpoint, it's also very driven by certain cost measures. So it is multifactorial. Yes.
I'm sorry if you mentioned this. Are technicians licensed?
Yes. Well, so our technicians, most of them have license. They are licensed. Yes, but not all technicians are licensed.
Okay. I'm sorry. They're not nurses, right?
They're not nurses.
Okay.
No.
So if a technician in this scenario, if the technician misjudge the situation, where does the liability fall? Who does it fall on?
So the technician follows the standard of care practice guidelines. So if there's anything that's outside of their scope, they shouldn't really be answering it. So if there's a question that's not answered through that, they should be, forwarding the note to the physician and doing that. In terms of if there is a mistake that happens, I think ultimately it would fall on the physician. I don't think there's any medical liability on other people. So it would fall on the physician.
And then just going off of Dr. Cohen's idea, what about medical, no, well, yeah, like interns, volunteers, not volunteers, interns really, or medical students to help out with this?
Yeah.
Is that something that's feasible?
That's a great idea.
Because I know it's used in behavioral health. Like I know, for instance, Henry Ford, they use a triage just because the wait is so long to see outpatient behavioral health services.
Yeah.
They use like master's level or interns to help. I mean, it's kind of brief, but at least get them in and do an intake at least, and then they move them along to see the full the therapist.
Okay, is that they're part of the institution, like they're hired and they get paid for this, or is it like a voluntary position?
I don't know the details of this, but I know oftentimes they get either they don't get paid, they get hours as part of their training. That's requirement for their training, or they get paid but it's not expected to be like a very high salary. Or anything like that.
Right.
Yeah.
Okay. Yeah, no, that's a really important ask. I think when it comes down to medical students per se, there's a lot of limitations on how much they can interact with the EMR. Like they can't really write certain things unless they're in certain clerkships. So there's going to be some challenges if it's not like a defined work, like what you said, like if maybe for a master's program, they have certain number of clinic hours that they have to master or do, and it's through the institution of University of Michigan, then they're sort of covered in that sense. But I think if we were saying, like, if we all of a sudden asked our medical students to help out with the in-basket, perhaps someone from the medical school was like, what are you having our medical student answer your in-basket burden? There would be like, what is the level of education that exercise is providing? So it becomes a little trickier. So I think for medical students per se, there's a very specific curriculum of what we're expecting them to understand for ophthalmology, and it may not be the best of their hours to answer our clinic and basket for, like, can I have my Timolol refilled? And what dose should it be refilled at? Things like that. Yeah, so future directions, just sort of examining the scalability of such answer lines across the system and seeing if whether it could be piloted in various outpatient departments, having that idea of having people who are interested in practicing at the top of their scope without feeling like it's just something that they would have to address. Consideration of other allied health professionals aside from nurses to look into these opportunities, like what we've done with ophthalmology, the use of technicians who are not nurses, and then cost of implementation or savings from the existing system. So kind of comparing and contrasting. I think whenever you have a new proposal, it's always nice to come up with some numbers when you're talking at the systems level to help facilitate that either buy-in of that process. And then does this allow physicians to focus on patient care rather than being asked to find times or admin stuff that they're really not as interested in? I would much rather just see the patient versus trying to find more times in the clinic that may work. And does that ease the cognitive burden on physicians? So These final slides are just more about my ergonomics interests and the fact that musculoskeletal diseases are very prevalent in ophthalmologists. We're at like 2.5 times more increased risk for having back pain, neck pain, upper neck symptoms because of the equipment that we use. So the slit lamp has a lot of cervical spine issues as well as the lumbar spine. And why does that matter? So pain actually impacts our work. Like anyone who has any degree of pain can tell you that it definitely will decrease their efficiency, affects their decision-making, and also decrease communication and collaboration. So these are some of the other projects that I'm interested in with regards to ergonomics. So looking at fatigability models of sustained movements. For our slit lamp, we have to hold out the 90 diopter lens, which means I'm sort of just holding out my arms for extended amounts of time. And over 100 visits, 100 patients a week, or, I say 40 patients a day. So 40 patients times 5 days a week, that's how many times I'm doing these. So even if it's for a minute or 2 minutes, that's actually quite a long time for your upper limbs. And so the MRI scan is actually a real one of an existing ophthalmologist. These are not HIPAA violation. He's gone viral. He's very proud of this. This is Dr. Maskett's MRI. So this is what a normal MRI should look like. That gray structure that you see along here is a normal spinal cord. It should look like that. And what you can see in his MRI is that there are definitely areas of stenosis or thinning of the canal. So you can see where the bone is actually impinging. There's an increased lordotic curvature by the red arrow here, by the hyperextension just from using of our equipment over time. So he's really passionate about ergonomics because it sort of affected him later on, and it is part of my belief for younger ophthalmologists to train them about how important this is, and we're trying to make sure that newer residents are aware of this. So yeah, go ahead.
Is this the kind of thing where like, man, if everyone really wants to build this more ergonomic slit lamp, but we just can't think of a way to build it? Or is it just like no one's really talking about this and we just sort of have grandfathered in this old equipment? And,
Yes.
Okay.
Yes. So it hasn't underwent like a facelift in like 100 years, ever since it was invented. It was not ergonomic for the patient. It was not ergonomic for the physician, but it does its job of allowing us to see into the eye. And I think the biggest push is that physicians are really not that great at advocating for new equipment. We're just like, oh, we'll just make it work somehow, right? And so if there's no demand for modifications and we're not going to pay more to buy a new slit lamp, then why would industry be fueled to come up with a new design, right? And then oftentimes, even with our microscopes, like they have great graphics, they have great ideas, right? But the end user, unlike Apple, unlike other forms where they actually ask a lot of feedback, like, how do you like it? What's your feedback? No one ever asked that much of medical equipment. It's like designed and then we sell it. And then you use it and you're like, it's really hard to do X, Y, and Z. And they're like, yeah, well, that's what we have. Good luck, maybe we'll come out with an extender or slight modification, but I really wish that there is some role of the end user being involved in part of that decision making so that you can come up with better equipment, so that we can make suggestions because we're the ones using it day in and day out.
So Inez, does that also suggest, we haven't talked a lot about equity in today's class. One of the things I was thinking earlier when you were talking about people who call, they're told, okay, like we're going to give you an appointment in 3 months, and they yell and scream and say that's too long. Like there's an equity issue there, but I'm wondering from the provider side, is this having impact on women who are small being disenfranchised, or people who are very, like, are there kind of equity issues with the equipment itself in terms of who is able to do this work or who is shortened in their career?
I don't know. So there's actually a dichotomy at both ends, right? So you have super tall people who this equipment is really damaging for it too, because they're having to constantly hunch over. Their necks and their lumbar spines are also not supported. And then you have people like myself who are super short and we're like super hyperextended to be able to reach. And sometimes we have to stand in order to accommodate. So I think when you're at both extremes, it is really hard. And in a recent study that we did with medical students, we kind of assessed their ergonomic assessment throughout their shadowing experience. And a lot of what they use or how they see is using a side slit lamp. So there's a side scope in which they look through. And then that height of that side scope is limited, right? So it's a perfect height for maybe if you're like 5'6" to 6 feet. But if you're over that or under that, you can either have a problem where you can't reach the side scope to see, or you're having to constantly like bend down really far to always see it because it doesn't extend, it doesn't bend. It's just one thing that comes out, right? And so there's the talk of like, why can't we make some of that be like displayed on video? Why are we making med students lean over to look through this tiny thing while we move the slit lamp around? So they're constantly trying to follow this like one little piece. Like, are there other ways of creating a better experience of what they're seeing? And the med students that we surveyed actually came up with some ideas like, why can't there be a monitor? There's a lot of interest in like heads up display, especially for surgery. But that's a different realm because there's actually poor ergonomics with that. However, they'll tell you it's better ergonomics because they want to sell you this super expensive device. But yeah, so there's a lot of, I think, room to figure it out. But yes, it's definitely not equitable when you're on either extreme. So if you're in that small group of height specification, actually specifically like torso length and leg, because if you have longer legs and a shorter torso, you're also challenged both at the slit lamp as well as at the operating microscope. Yeah, so don't go into ophthalmology if you're short torso. I'm just kidding. And so that was the end of my presentation. I have my LinkedIn as well as my email. So thank you very much for this opportunity, and I'm happy to answer any other questions.
So let's take just a few minutes. I know this is kind of the part of the semester where it's dark out and you have lots of work to do, but thoughts or ideas that we haven't shared that might just spark something for Dr. Zhang to be thinking about differently. So we've talked a little bit about bringing in retirees, and we've talked about new equipment in the room, and we've talked about change management. We could raffle off gold parking for people who ensure that their message is the best. So what else?
Yeah.
Oh, go ahead.
Is there any sort of like prioritizing that can be implemented when it comes to like the in-basket? Like 80% of the in-basket messages I've inadvertently sent were prescription refills. I did not I'm not trying to actually send it to my physician. I don't think it's urgent. That's just how the system does it.
Yeah.
But is there any way of just being able to try and flag that and say, okay, all prescription stuff can go in like this one basket. It's presumably not super urgent versus like, this is new symptom, concerning symptom, follow up somebody who's recently had surgery, etc.
Yeah, I think that better categorization of the different baskets would be really nice. And then I do think for ophthalmology, we do have a way, I'm not sure how they do it, of at least removing some of the refills, like what you're talking about. I think the other part is when patients are asking about billing questions, like no provider can really answer that for you. It should be going to the billing office. And so I think the biggest problem is I don't even know like what's in these in baskets and how they're categorized. But yes, if there's a way to like better like have a heading of what they are, and then actually assign an in basket that addresses that heading, that would be ideal. But I think what becomes difficult is if you're asking the patient to pick which heading, right? Because sometimes like it could be a prescription refill, but I also have a question about something else. So which of these do I click on? So, yeah.
Sort of building on that point, do you think there would be like space to have some sort of mapping system for the patients before they even go to that portal to ask the question? Because I know that I've asked questions in my primary care portal that, you know, I just don't know where to go to ask those questions. And I think it's confusing sometimes to know whether to call or to be online, because sometimes I try and call like CVS for a prescription and then they are always like, you should be doing this online because it's easier and
Yeah.
or on the app versus, but here it's like, no, you should be calling. So like maybe there would be like a good way to like map the questions if they can be easily categorized. Like, is this a billing question? You should be reaching out to this person instead. Or like, if you have this problem, you should be calling this number
Yeah.
before they can actually get to that portal to even ask the questions.
Yeah, that's a great thinking process. So my colleague Diba Minhas and I are on the portal subcommittee. And recently it did undergo a slight revamp addressing some of that, where there would be like less confusing text and also better framing. Like if it's a billing question, there's a link to answer that. But certainly any other avenues that you can think of to better educate the patient while you're on the portal. We just didn't want it to create it to be too busy or make it seem like we don't want you to have access to the portal. But but the new design does look a lot nicer. Like if you log in, I think it's been implemented, you should see a much more like clear, less text, more information of what categories they are. So there is, I do think it's important to also like educate the patient on what things the portal should be used for versus what platforms it doesn't cover. Yeah.
Let's get one more.
Oh, go ahead.
The slit lamps, are those, is the microscope digital or physical?
It's physical.
Okay,
It's
that
a,
makes
it's a
sense.
microscope. Yeah, it's a microscope. There has been, everyone has just said, oh, well, we'll just go digital and it'll solve all of your musculoskeletal complaints and all of your issues. But just like anything else, like technology and AI related, how many more years will it happen? And how much will it cost when it does happen? In that time, I'm aging, like that's another decade, another two, and that might be retired. So, you know, if in 2 decades it goes digital, myself, my colleagues, all the people who are still coming out are still getting these complaints. So I think that's where like there's been a lot of talk like, yeah, I mean, this is everything that you see is digital. We're going digital, but like when is that happening and how much will it cost to go digital? Like for everyone to go digital. So yeah.
Okay, thank you again, Dr. Zhang. And thank you all for being so engaged this semester. And I hope that the next week or so is not too painful and that you get some rest and take some CHEPS or something to at least give you a little sustenance. And I think we're done. So thanks to all of you as well.